I'm now going to introduce a Frisco resident, a doctor here in our community, Guy Culpepper, who's actually very special in my heart because he and I were both born in St. Paul's Hospital down in Dallas. So how about that? He has actually been named for 21 years in a row one of the best doctors in D Magazine. He was the president of the medical and surgical house staff at the St. Paul Medical Center, where we were born. Just want to point that out. And he is actually the CEO and president of the largest physicians healthcare group in the United States, 240 doctors that he oversees every day, and they call him boss. And tonight we're just going to say, Doctor, tell us what you know.
Well, thanks for having me. I was told tonight I could speak for about 30 minutes, so for all of you who have waited in a doctor's waiting room and been told the doctor will be with you in a few minutes, but you know, I figure I got about an hour. Can I use the microphone? Can I raise this thing up a little bit? I've done enough talks to realize that these things are never tall enough. I've also done enough talks to realize that you are the guys that make a difference. Because the thing is, there's a whole bunch of people who could be here tonight, but y'all are the ones who did show up. Thank you. I'm Dr. Culpepper, and I ain't running for nothing. And you can't make me. Tonight we're going to talk about who put the hell in healthcare. And one of the things that I want to call to your attention is the way that not only affects your lives, but the way that it's affected your doctors' lives and the way it's affected the life of our country. But you know, if Obama had done as well in school as most of us, he would have realized that all you got to do is look back at history, or else you're destined to repeat history. And so I want to take just about 5 to 10 minutes and give you guys a little insight into how did we, in fact, come to think that we needed health insurance. Those of you who can't see the picture here, Obama says, "Look, don't tell me. I think I know this one." Fact is that he doesn't know this one, because if he paid attention, he would have seen that for 100 years of healthcare development, we've already seen that the plan that's been put in place is destined to failure. The first national health plan was put in Germany in 1880s by Chancellor Bismarck. Now, from that time, Drinda, can you turn my computer around so I can look at it and I won't have to look at my screen? England actually developed their national health insurance plan in 1911. And then most of the European countries had one 100 years ago, 1912. Teddy Roosevelt was going to run for re-election based upon instituting his plan, and he was soundly defeated by Woodrow Wilson because the country said, we really don't want that kind of stuff here. Now, there were a lot of labor union fights in the 1920s, really powerful battles. Warren G. Harding ran on a platform of anti-insurance reform, and he won. You see, throughout history, over and over again, when people have tried to institute something to the wonderfully independent Americans, Americans have said, well, you know, now we think we'd like to make decisions on this process. Something that a lot of folks don't realize is the first hospital insurance was formed right here in Dallas at Baylor Hospital. Now, the way that came to be is that a school superintendent took a job on the board there at Baylor and said, I think these teachers would pay 50 cents a month if we could guarantee when they get pregnant that they could have 21 days of hospital coverage. And he went to the teachers union, the group that he had worked with previously, signed them up, and Baylor Hospital formed essentially the first hospital care plan back in 1929. Subsequently, the nation said, hey, this looks like a good idea. The economy, of course, then tanked through the Depression. They decided that prepaying for hospitalization would be a great idea. And for 50 cents a month, 75 cents a month, you could get yourself coverage at the hospitals. The country, meanwhile, was looking at, can we get socialized medicine and get the, Roosevelt wasn't able to pass it. One interesting thing happens here. When did health benefits become the expectation of our country? Well, during World War II, the government came along and froze wages and said, we need no wages to be raised. So very innovative companies had to compete for employees by offering benefits. Now that created a culture of getting your company to pay for your health insurance benefits as a result of a government policy. Blue Cross Blue Shield saw these opportunities, and how did Blue Cross start? You remember those hospital care plans? They coalesced together to form Blue Cross, which was, they decided if we get together, we can compete, we can stop competition, we can control rates within a community by forming networks of these hospital plans, and let's have a rule that nobody can move into our network, into our community to compete with us. That way we can keep hospital prices high. It was true 80 years ago, continues to be true now, that competition is what lowers price, and when people want to control price, they try to eliminate competition. The first thing the insurance companies figured out as well is that by not insuring people that were sick, they could make more money. If you got to pay for it, it doesn't work out so well. So what they did is that they only would cover people who were employed and who were under the age of 66. Then they developed a significant funds to continue marketing this policy, and very smartly went to these employers who had been forced by labor unions and cultural shifts to provide insurance, and again said, look, if you're not employed, we're not going to insure you. So you wound up with a tremendous money-making opportunity. Now, what you go along, a moment ago it was mentioned in 1965 that Lyndon Johnson passed Medicaid and Medicare in one big sweep of the pen. I want you guys to look at something on this chart. One point, and if this is a graph, it's got to be science. Now, what you see right here is that in 1965, you look at this curve, this is hospital costs. And you see that in 1965, when Medicare was put in place, that all the costs of physician fees and all medicals stayed about the same. But look what happened to hospital reimbursement. A tremendous escalation. In fact, it was so dramatic, and go back to that point of if you don't watch history, you're destined to repeat it. It was so dramatic that right on the cover of the New York Times in 1971, they wrote that the lesson we've learned by the abrupt introduction of Medicare in the mid-60s was that the addition of a new volume of patients and a huge demand of service without a corresponding increase in resources produced appalling inflation. Now, this is 1971, and what they said in the New York Times is, my God, we hope we never make this mistake again. Somehow, somebody doesn't read the old editions. Richard Nixon invented HMOs, subsidized insurance companies. We got, in the 1980s, a tremendous increase in corporate America in the hospital levels. And the hospitals became very powerful and started to broaden their services and actually control the healthcare market. We're seeing a continuation of that today. And in response, you see now, bringing us up to date, the Affordable Care Act. For the next few minutes, I want to talk to you about the Affordable Care Act and how this impacts physicians. One thing in particular, though, that we knew then, we know now, that if you think health care is expensive, just wait until it's free. Over and over again, when you make a product or a service free, you raise the cost for everyone else. It was mentioned that I'm the head of the Jefferson Physician Group. Let me tell you what this is. About 18 years ago, a group of primary care doctors and I got together and realized that primary care was in danger. We said that primary care physicians are vanishing. They're going away. And what happened is we went into this profession knowing that we would be the lowest paid, and we were okay with that. You don't go into pediatrics or family medicine or internal medicine if you're wanting to make the most money in medicine. But the discrepancy between what was happening to primary care salaries and what was happening to everyone else in healthcare started to widen precipitously. Precipitously. And not only that, a real scary thing was happening. Fewer and fewer doctors were going into primary care. Now, this is where we're at this point. In fact, if you guys think about, what are we a country of, 600 million? Y'all know the numbers maybe better than I. I'll tell you what, we train 2,500 family physicians a year in our country. And of those, about 18 years ago, half of them stopped being American graduates. Now, let me put that in reverse. It means that of the physicians that are training to be family doctors, only 800 to 1,200 a year are American-trained physicians. To serve a country of 600 million people, we're putting out about 1,200 American-trained family doctors a year. Now, you don't have to be a rocket surgeon, as George Bush said, to do the math on that. You realize pretty quickly that this is not a sustainable product. Thomas Jefferson laid down a whole bunch of great rules when he helped the founding of this country. And I put this slide up here as a transition because you see, of course, as he said, those of you can't read it there, I'll read it for you. The democracy will cease to exist when you take away from those who are willing to work and give to those who would not. Now, there's just principle after principle that's being defied here that those of us with greater wisdom understand. What's happening in healthcare right now is that we're finding a vanishing resource of primary care and a system that's being built entirely around primary care. Every aspect of saving money of the Affordable Care Act is based on access to primary care doctors, and yet hardly any of the conversations have been positioned around, well, now, if we don't have primary care doctors, how's that going to work? Somebody at our country has to say, stop all the noise, and let's go back and say, wait a minute, if we're going to go mine this gold on the moon, how are we going to find a rocket ship to get there in the first place, right? How are we going to get there? A lot of what's disenchanting to physicians is this thing where we're being bean counters. You hear of the beauty of electronic health records and everything is computer. So now when a patient comes in to see me, the way I'm measured, the way I'm judged as a quality doctor is if all my little boxes are checked on my electronic records. So I appreciate the opportunity to see y'all, but I got to pay attention to my computer today because this is how I'm going to get paid. Well, this system is starting to propagate itself. Now, when I was trained at Parkland, I came out of residency 27 years ago, so I've been in private practice 27 years. Even today, I'm sure it's the same way. At Parkland, we were taught that there's one way to practice medicine, their way, everybody else is wrong. And the thing is, you'd get judged as a doctor by how many tests you could order. You'd go to morning rounds the next morning, and the chief would walk in, and folks would kind of clear the trash out of his way as he comes down because he couldn't see it or he'd get angry. And then he would say, Dr. Culpepper, how many tests did you order on that patient? And if I could name more tests than the resident next to me, then I was his pet. And if I could think of the most esoteric, unusual diseases and order a test to rule it out, then I was a gifted student. Well, this type of healthcare training, as you're not surprised, turns into that kind of healthcare practice. You go into practice thinking that I'm a really good doctor if I can order every test I can think of on this patient. And then now, in between me and that patient, I've got this computer, so not only do I need to order every test I can get, but I need to come over here and make sure all my boxes are checked or I'm not going to get paid for it. I sometimes think I'd do a whole lot better if you just sent your representatives in to talk to my representatives. Meanwhile, you wonder, why are these primary care doctors starting to kind of lose their heart? Why are they not wanting to do this? what you got to take home tonight is it's not about the money. We didn't go into this to make a boatloads of money. We went into this to enjoy this brilliant, noble profession. But along the way, the hell in the healthcare is taking the joy out of the healthcare for us too as doctors. There's nothing at all in the Affordable Care Act that makes life more rewarding for the primary care doctors or for the patients. Nothing whatsoever in there. This highway to healthcare hell, as I mentioned it. One of the things I learned as soon as I got out of that ivory tower training at Parkland is that my patients didn't really care so much about all those tests. And it struck me really hard when one of the first patients I picked up in the emergency room was a brilliant scientist that had worked with the rocket program that was developed at NASA, and he was in the process of dying. Now, what you do is you go and you pick up what were called strays in the emergency room. That means a person shows up in the emergency room and they don't have a primary care doctor, and so you're on call to take care of them. Well, this fella did not have a primary care doctor, showed up in the emergency room in the process of dying, and I went in and sat down, and being so bright coming out of training, I figured I would order all these tests and he'd know I was a really smart doctor. He looked me in the eye. I'll never forget this guy's eyes. And he said, "Dr. Culpepper, I just want somebody to listen. I just want somebody to explain some stuff. And I really don't want all those tests run." And he proceeded to tell me about his adventures in developing rockets. He proceeded to tell me about his life as a research scientist. He didn't give a rat's about whether I was going to be able to keep him alive for 4 months instead of 5 months. He wanted somebody to know he'd lived. Now, you got to understand the core of that, because a lot of what's happening in healthcare is this management of quality based on quantity and numbers and tests, and you're going to hear more and more of it. But somewhere in there, a lot of us, we just kind of want to know, do you know that we cared? Do you know that we were alive? Do you know that I'm a person? Well, at primary care, when you're looking for an advocate, that's where you got to find it. Any of y'all had a family member in the hospital? For God's sakes, don't let them go in the hospital by themselves, right? First thing you do. It's the same thing with the healthcare system. Don't go into the healthcare system without a primary care doctor. And yet, only 30% of patients have a primary care doctor. 30%. I'll show you a couple of things. I do tweets. Now, if you guys ever, I welcome you to follow me on Twitter, Dr. Culpepper, at Dr. Culpepper. Yeah, on Twitter. Yeah, so on thank you, Junior. So follow me on Twitter. One of my tweets recently that I put out to give you is the art of medicine is remembering the uniqueness of each human being. Science is repeatable, but people are one of a kind. And you understand the point of that. To take you into another real-life example, my wife and I went on our 27-year anniversary this October. And we went to Jackson Hole, Wyoming, which was glorious. I took this photograph there. I just thought that outside of Texas, I'd never seen any place more beautiful. And we waited till Tuesday morning when the weather cleared up to go into the national parks. And this was a special time, because being a doctor, I don't take a lot of vacations, as some of my office staff will tell you. So Tuesday morning, we got up early and we hopped in the car and we're going to drive into the national park. And this is what we found. Right? It's a barricade. Now, what I want you to notice when we drove up here is this is a dirt road. There's no people there. There's no structures there. There's not a dime of money being spent to take care of this place, except that which God spends. And so I'm faced with, do I violate this barricade and go on in here because we set aside this special time? We chose not to, because we said, you know what, let's follow the rules. Let's go somewhere else. And I've never been to Idaho. So I'll go to Idaho. Who would have known how beautiful Idaho was? Who would have known? I took this picture in Idaho. Sun was shining, the creek bed was flowing through there, and my wife and I, we held hands. Here's the point. When you get a barricade thrown up in front of you, Americans go around a barricade, right? We follow the rules, but we find another path. Well, see, this is just like healthcare. We got all these rules in front of us and all of these problems, and I could sit here and bitch a lot more about Obamacare, but what I want to do is I want to take a couple of minutes and tell you that the country is not looking to us to bitch more about Obamacare. What they're looking to us, especially the physicians, is to say, give me an alternative. Give me a side road, another option. Now, I'll tell you, too, as a doctor, as a family doctor, anytime I'm told you can't do that, one of my jobs for you is to figure out a way that you can, right? And the saddest part about Obamacare is that what we're seeing is simply not going to work. But the thing is, we still need it to work. Because when all this yelling and all this heartache is over, we still got 30 million people that are uninsured. And we know that this system is not going to help them, but we know we've got to. And the reason we know that, and I think this appeals, and everyone in here understands it, the truth about fiscal conservatives is not that you don't care, just like for doctors. It's that we know we can't afford to waste the money to get there. It isn't that we don't want to spend the money. It's like parenting. When you say no to your kids, it isn't that you don't love them. It's that you can't waste money because you know that you only got so much of it. When I think about the conservatives that I know, they're the ones that after the storm, they're the ones that rebuild. They're the ones that are paying the taxes, and they're the ones that are raising the children to make the world better. It's up to us to not just bitch now about Obamacare, but to say, hey, we got a solution. And so I'm going to take now about 8 minutes and go through a simple solution, and then we'll open up some questions. I didn't have $1 trillion in 6 years in office to come up with these. So I only got 5 pages. But what you'll see is that these 5 pages make more sense than everything in those 1,200 pages. First off, we got to have an open marketplace. What fool doesn't realize that unless there's competition, you got prices go up? There is not a single thing in the Affordable Care Act that actually makes me as a doctor or my neighborhood hospital trying to lower cost. Nothing. There's nothing in there. There's no action to change. We need to, and this is such a no-brainer, we need to eliminate this artificial grouping of where, well, if you're an independent businessman and you go buy health insurance, we're going to have to charge you a different rate than if you were working for General Electric or Microsoft. You know, when it's all said and done, you're kind of in the same big pool of that insurance company. They don't sell their stock based on, well, no, we're only selling stock for the pool over here. We need to eliminate that artificial grouping. And we need to have transparency of prices. In the spirit of what I tell you about also finding an answer, I created about 8 years ago a thing called the Jefferson Independence Card. And this is about transparency. It always struck me as painful that you go to the doctor and it's on the way out the door that you're told how much it is. I mean, imagine if you went to Albertsons to buy groceries and it's on checkout that they tell you, you know, that bread you chose there is $85, right? Well, you go to the doctor like that. It's ridiculous. So what we needed to do is to have a system where people say, before I get to the doctor, I know that EKG is $35. I know that CBC is $15. I know the office visit's $78. And I can sit down and figure out that I'm going to need $224 to go see this doctor. There's nothing wrong with that. We should have the same thing at the hospitals. And so we as Americans need to be asking, why don't we have that? I'll tell you as a primary care doctor, I said, never mind why don't we have it. I'm just going to go ahead and put it in place. So for every cash patient that I see and have seen for the past 8 years, they can go online and they can see exactly how much the costs are for the services that we offer before they get there. I've gotten 400 doctors to sign up for this. You know, in imaging, when you go to a hospital to get an MRI of your knee, you might get charged $4,000, $5,000 for the same thing that you could go pay cash for and get it for $800. And when I say the same thing, I mean the same magnet, the same resolution and image, and the same radiologist reading the MRI. I mean the same thing, baby. Besides the open market, we need to reward the patient. Now again, this goes back to my skill as a parent, because unless I set up rewards for my kids, it was hard to get them to do stuff. Well, we need to incentivize patients and pay them or reward them for making good choices. So I mean, seriously, if you don't smoke, you ought to pay less. If you come in and do your follow-ups, you ought to pay less. If you get your physicals, you ought to pay less. The system needs to incentivize the patients. And this whole pre-existing condition thing, it's bunk. It's crazy. And you say, well, no, it's part of, here's why it's crazy. If you go work for a company, your pre-existing problems, they go away. We don't care about that if you're signing up with a big company insurance. Well, it's the same people insuring you as they are little companies. So, you know, why aren't these the questions that we're asking about? One other thing, this health savings account, Arlene mentioned, it's a no-brainer. And that health savings account needs to be tax-free and it needs to be cumulative. If I give you $1,000 a year and you know how much do people spend on primary care? In a typical year in my office, my average patient will spend between $300 and $700 a year for a physical and several office visits. 80% of people don't utilize all these crazy massive amounts of services. If it's your $1,000 and you can work with me knowing how much it is before you get there, and you know that what you don't spend of that money you get to keep and it rolls over into the next year, you're building up a little thing called a savings account. Well, we got to be able to implement that. Here's the other person. Now remember, I got 5 points. You've heard the first 3. Reward the primary care doctor. Because as I told you a moment ago, if you don't, they're not going to be a primary care doctor. There will be, and we're already, if you don't have a primary care doctor for right now, go out and get one, latch onto them, because they are going away. We're already seeing systems that are being placed kind of creeping into our culture where the organizations know there aren't going to be primary care doctors, so they start to desensitize you by saying, but don't worry, you go get your vaccines at the pharmacist. I can't tell you how many pharmacists have called me in a panic, my own patients that are pharmacists, and said, God, I don't know how to give shots, and my company is making me do it. They are allowing chiropractors, who some of my best friends are chiropractors. Well, not my best. But they're having them do sports physicals on kids, and these guys are not trained with stethoscopes, but it's okay to go get your sports physical there. Now, we're also reducing the requirements for nurse practitioners and PAs, which I have in my office, and they're glorious, but we're reducing the requirements for physician supervision for them. And the reason is so that we can start to get the American people to realize that you don't actually need a doctor to deliver care. And you'll see these great articles about how 2 out of 4 nurses can treat a bad cold as well as a doctor. Y'all, bad colds get well on their own. You see, the thing about being a doctor is like delivering babies, right? It's like 9 times out of 10, God takes care of it. And you want the doctor there for that one time that it didn't, right? Well, it's the same way with sickness. And when you go into my office, the reason you're seeing me is not because you don't already kind of know how to take care of your cold or your sinus infection, but while you're there, I might find something else. And you kind of know that, and you need that experience. You know, when you pay me $100, you're typically paying me about $1 for what I did and $99 for what I knew not to do. We got to reward the primary care doctors. And one thing that folks don't realize, that if you have another message to take home, independent primary care doctors, what does that mean to you? Well, now you saw when Obamacare and the Affordable Care Act went into place, the hospitals were some of the first people to rally around that and say, hey, we're opening this ACO with this insurance company, and we're recruiting all these doctors, and now you see you've got the THR-related physicians and the Baylor-related and the UT Southwest and the Methodist. Well, those are not the independent doctors. And how is that relevant? Well, hospitals, by their negotiating power, can get paid a whole bunch more than an independent doctor. And what happened with Obamacare is that they were now able, instead of just employing doctors, to go and affiliate with them in a clinical way, and now the doctors get to participate in that much higher reimbursement rate. I'll show you the numbers in just a moment. Why would the hospitals want to do this? It's because once a doctor is feeding at that trough, he's obligated to refer all of his cases into that silo. Now, they can't sign you a contract, say you must refer them all. They'll use language like, well, when it's clinically appropriate, we prefer that you utilize our facilities, and we're going to allow you to participate in our contracts on part of that. But then that doctor is monitored and everything is counted to make sure you are using that facility, or maybe we don't want you to be able to participate in our contract anymore. Now, how does this affect you as a patient? If you come see me, it may turn out that it's better to get your cancer care at UT Southwest, or your hip replaced at Baylor, or get your heart fixed over at THR, and you and I need to be the ones to decide that. When you lose, only about 30–40% of the primary care doctors in the community are still independent. When you lose that independent doctor, what you have lost is a true competition in the marketplace. Now, those of you who are affiliated with hospitals, you understand as well as I do that there is collusionary activity. Each of you knows what the other is charging at your prices, and not either one of you wants to lower those prices. So these systems that are being used, as any good business would, are being used to preserve revenue, being used to keep prices up. Problem is, that's not what's good for America. Competition, free marketplace is what's good for America. Let me show you a couple of number examples to reinforce what I just said. This is, and I'll read these to you because that bright light, I see, knocks this out. But let me tell you, a nurse visit, if you are an independent doctor, you get paid, and what are these numbers? These are 2011 Medicare numbers. And this is relevant to those of you in the room who are in Medicare and you're trying to figure out, why can't I find a family doctor? Well, I can't find a doctor anymore. Only about a third of the doctors are taking Medicare patients, despite what the government's saying. And frankly, only about 10% of them still speak Texan. Now here's the thing. If you go and you get a nurse visit and you're independent, you get paid $19. But the minute I put Baylor or THR on my front door, I don't have to move. My same building, same everything, same staff, not a thing changes except I put in little letters Baylor or THR or UT Southwestern. I now get paid $61 instead of $19. And for a routine office visit, Medicare would pay me $68. And if I put the hospital name and I'm now affiliated, I get paid $124. And for a complex visit, Medicare pays me $137, but as soon as I'm affiliated with the hospital in a clinically integrated way, I get paid $235. So all these doctors that are feeling pressure to become a part of a hospital system so they can organize to lower cost, you got to understand what really is happening behind the scenes. Pull back the curtain. Follow the money. Primary care, we've got a 30,000 to 50,000 physician shortage right now. Face it. Now, why do I use the dodo bird up there? So as I tell our family doctors and pediatricians, the reason the dodo went extinct is because they were too nice. You know the story of the dodo. These sailors landed on the island and the dodos wouldn't run away. They just sit there and get eaten. Well, the primary care doctors, when you go to medical school, pretty much the first day of medical school, you can tell what specialty guys are going into. Because all the really nice guys go into pediatrics and family medicine, internal medicine. And in fact, there was an old joke in medical school said that when you finish medical school, if you still can talk to patients, you ought to go into primary care. And if you can't stand to listen to them, you ought to go into anesthesia. And if you feel like hurting them, just go into surgery. This is a chart that shows you the numbers I showed you a moment ago of the number of physicians. These are the positions to train family physicians in our country, and this is the number that are American trained. And you see that starting in about the year 1997, it declined precipitously, and it has not recovered going forward. The American trained physicians, the total number of slots at around 2,400, and the slots filled by American physicians. This is a slide that may sure a lot of you know how it feels. Say, I'm sorry, doctor's not taking any new patients. He doesn't even like the ones he already has. I had two more points. I appreciate your tolerance. I wind up talking for 30 minutes. It only feels like an hour. Enhance education. You see, the thing is, these great institutions that we already have in place, the Parklands, the community colleges, the nursing programs. If you come to me as a taxpayer and say, I want to take your dollars and I want to give them to somebody, I don't feel nearly the burden if you're giving them to educate. I don't feel nearly the problem if you're raising up. And then if you take these exact institutions that are in our communities and say, and what we're going to do is we're going to make y'all responsible for, guess what? The people in your communities. So that we're going to have you take a Parkland and take our county numbers and take and set some clinics up in the communities. Take these teaching programs and you can identify the patients of need now. Have the systems that train take care of the patient. When I trained at Parkland, we took great care of folks. I'm pretty much expecting they still do. We have systems in place if we just expanded those instead of reinventing the wheel, and expand education. One other thing, the ability to have your debt forgiven. You know, there's a lot of people that say, I can't go to nursing school or I can't go to medical school because I can't afford it. I think if we can enhance a program that says, no problem, when you finish your training, come spend a year here, and we will significantly reduce that debt. And you can have an ongoing flow of those students going on. The final point in terms of the solution is to use technology, because a lot of the things that I'm talking about tonight were simply not possible 3 and 4 years ago. But what I can do now in real time is I can see one of you in my office, and I can look and I can find out where the most cost-effective care for you is instantly. I can see the numbers of an orthopedic surgeon, and I can find out that this one has a $28,000 cost for his hip replacement, and this one has a $16,000 cost. But wait, you don't want this $16,000 because his readmission rate is higher, or his infection rate is higher, or the hospital that he works at has a higher complication rate. This kind of data we can use that we could never use until just literally the past couple of years. There's another aspect of data. We can identify those patients that are repeat offenders into the emergency room. I'd rather spend $50,000 for a nurse practitioner in a community to follow up and call patients instead of $600,000 for that patient to show up in the ICU. The technology is going to be there to help us with this. So to summarize that, the 5 points are the open marketplace, reward the patient, reward the PCP, enhance education, and utilize technology. My opinion, this is a platform that the fiscal conservatives need to adapt. They need to absorb, and instead of just yelling at this Affordable Care Act is going to be the death of us, we need to instead say, y'all go on about this nonsense. We're instead mobilizing to find a solution. I think if we don't do that, then we have done a disservice to our country. I'd like to answer questions, and I'd like to thank you for your tolerance.
Yes? Recently a relative was in the hospital extended period of time, and there's this new term called hospitalist,
Yes.
and so we never saw the same doctor. We had to explain over and over. There was no continuity. Can you kind of elaborate on this hospitalist business?
Yes. In fact, again, having transitioned this generation, when I came out of training, when you showed up in the emergency room, I would come down and admit you to the hospital. About a decade ago, it became more popular to utilize an internist who that is all they do within their practice, is to manage you in the hospital. So when you show up at the emergency room, I get a phone call, and it turns out you need to be admitted. I tell the ER doctor, okay, would you admit them to such and such, the hospitalist? Now, on the one hand, that's depersonalizing to the patient, because I know you need to see me and you need me to be there because we have a relationship. But what would happen in practical terms is I'd be in my office with another 20 patients that day, and the nurse on the floor would call and would say, Dr. Culpepper, Mabel's just not doing so good. Her color's off, her breathing's bad, and I cannot get to that hospital in time to really deliver the quality care I would need to. So having a hospitalist there who would go and see the patient and then report back to me has actually turned out to be an improvement in care. The important thing, though, is to have your primary care doctor have a relationship with that hospitalist. It's much like if I have a relationship with the cardiologist you see, or the pulmonary doctor, or the rheumatologist. A lot of conversation goes on behind the scenes. If I finish seeing patients at 6 o'clock at night, it is not uncommon for me to be at my office till 10, 11, midnight, 1 in the morning, a couple of times a week, in order to follow up on the phone calls, the letters, or to see what's happening to your care outside of my office. That is also something, when you hear about a patient-centered medical home and you hear that language of what is this patient-centered medical home, a lot of that is an effort to recognize that what a primary care doctor does in talking to the hospitalist or the specialist, or in coordinating that care after hours, early mornings, late night, that is not reimbursed by one of those $68 office visits. You think about it, I might see some patients 3-4 times a year. Each time I see them, I get paid a $68 or $70 office visit, and then meanwhile, I've got 12 or 14 letters during the course of the year from a specialist, or their family members calling my office about, hey, she's having this problem, she slipped and fell, or who should I go see for this orthopedist? And there's nothing in the system to reimburse me as a primary care doctor for all of that mass of additional care. Hey, one other thing you guys will find interesting. You've heard of HIPAA?
Yes.
HIPAA, right? Okay. HIPAA is this Patient Privacy Act. So I get a friendly letter yesterday from our insurance agent who does our office slip and fall insurance. And he says, Dr. Culpepper, I just wanted to warn you that your policy that only covers you for $100,000 for a HIPAA violation, it is grossly inadequate, and I'm going to want to recommend to you that you get a policy covering you for over $1 million, because the largest claims that we're seeing right now against primary care doctors are HIPAA acts. So in other words, I'm being told that I need to buy insurance to protect me from my government. You see, my overhead is going up so that I can keep from having the government come in and sue me for these privacy violations. There's just something that is rolling the wrong way with that. Yes?
In 2012, United Healthcare joined the Dow Jones Industrial group of companies that are leaders, as we know, indicators of who does best. What are your thoughts on the huge profits the insurance companies make versus the amount of money the doctors are paid, who are not paid enough for all the years of education you got and all the help you provide for the people?
I'm honored that you would be appreciative of my salary, but I'll tell you this, we're doing fine as doctors, we're making a good income. I'm tired of hearing that doctors, in fairness, even as a family doctor, and because I believe in transparency, so my answer to the first question about United Healthcare, people make what they make, but we should be transparent about it. A lot of people here don't realize that when U.S. Healthcare sold to Aetna, that the CEO of that company was paid $980 million. One person. A lot of people here don't realize that the heads of Blue Cross Blue Shield all over the country are making $5 million to $20 million a year. The average family physician makes about $160,000 a year. It's a great salary. I think that what our community wants is for the average family physician to be able to send his kids to college so they can become physicians. And so that when you come see me, you don't want me stressing about my house payment or, but we're doing okay. I saw in the newspaper, in the morning news, a couple of it was just last Sunday, when they were talking about a neurosurgery case where a neurosurgeon had been recruited by Baylor of Plano, and this neurosurgeon was paid $600,000 guaranteed salary to come in and start his practice at Baylor Plano. But his comment was the most startling to me. He then said, well, it's common for the neurosurgeons around here to make $2 to $3 million a year. I don't have any issues if that's truly what they're making, but it should be transparent. It should be transparent. We're capitalists, and if I can justify to you what I'm getting paid and let you know what I'm getting paid, and you feel like, you know what though, you're really worth it, I'll tell you where the heartache is. My sister went to Baylor Frisco to have a one-day procedure, one day, to have this pain transducer implanted. And she called me and she said, Guy, my bill for the hospital, I was there one day, 23 hours to be exact, and my bill was $98,000. I mean, where there are no words. You can't go to the hospital for one day and have to mortgage your house. I have patients go to the emergency room. You come to my office with a UTI, lower abdominal symptoms, you got a urinary tract infection, I get a urine culture, I do a complex office visit, and you leave my office and have to write a big check for blood work and urine culture and an office visit of, let's say, $240, and it seems like a lot of money. You go to the emergency room, somehow you needed a CAT scan because you had lower abdominal pain. Don't know why. Somehow that same urine culture was several $100s that I did for $25, and you leave there with an $8,200 bill for the thing I could have treated for $250 or less. And when you heard Arlene talk about emergency care and what's going to happen with this Medicaid expansion and what it's going to cost America, when you have increased, and you have increased utilization of emergency rooms, you got to wonder, what is that going to cost us? Have you noticed the news releases where, again, I hate to pick on Baylor, but they announced how they're opening all of these emergency rooms in these different communities? Well, you know why that is. First off, you saw the chart. As soon as you put Baylor on the door, it's a hospital, you get paid way more. Second, if you call this visit an emergency room visit, you get paid way more. Now, what does that do to these family doctors that are trying to move into those communities and establish a practice and get something going? Discourages them, or they just go and work for the machine. They just go work at that emergency room, right? And so now, what do you have for price competition? None. Building more emergency rooms is not the answer. They say it costs $10 million. Don't worry, we're building this beautiful new emergency room for $10 million. I have, 12 providers in my practice. 12. 2 locations. 18,000 square feet. We see over 30,000 patients. Our overhead is $3 million a year. There's no point in building emergency rooms in every community. What you need is you need primary care. And don't get me started on navigators. That's been the most heartbreaking thing to me. $50,000, $60,000 a year salaries for people. And so I have medical assistants in my office that I'm busting my tail to try to pay $35,000 to $45,000 a year. And they're telling me, Dr. Culpepper, I think I'm going to quit here and go be a navigator for $60,000. Turns out that you'd only need about 6 weekends of training or something. It's a heartache. Yes, ma'am?
I heard on the news that if you do go into a hospital, you better be sure you're admitted into the hospital Otherwise, there's a difference in whether your insurance covers it or not.
This Medicare, if you're admitted to the hospital, in fact, almost every Medicare admission, if you pay attention to it, will be admitted to what's called a 23-hour observation admission. Because Medicare, because of the way the payment schedule was, is that they would rate it differently, and if you were admitted for a whole day, if it was 24 hours or longer, there was a chance that the hospital would not get paid. So the hospital would send out memos and say, look, admit a 23-hour admission for observation. That way, if the patient was discharged within that time frame, we'd get a certain pay. If it's over a day, it might fall under DRGs or under a different payment system. So again, follow the money. Now, the fact of the matter is that can work in patients' favor too, because sometimes, I mean, seriously, go back to the slide about the tests. One of the worst things can happen to any of us as patients is get admitted to the hospital. The more tests you do to somebody, the more likely you are to hurt them. And the more tests you do to somebody, the more likely you're going to find stuff that needs more tests. It's common experience for me to have patients go and get a total body CAT scan just because they're feeling good. And so there's people I like to call the worried well. And so they get a CAT scan and there's a little shadow on an adrenal gland. And so then they come to my office. Well, now I'm obligated to order another CAT scan or an MRI or another test. I'd like to tell them, you know, look, it's a little shadow. It means nothing, but one test leads to the next test. So for a Medicare patient, it is sometimes a good idea to have as little exposure to that toxin as you can. Yes, sir?
I've heard that there's statistics on the number of people that die in hospitals because of errors. Like it's huge. Is that real?
Well, the fact is that most of us do go to the hospital to die. And so statistics are can be played with. What's interesting to me is the dramatic statistic that says how much less death occurs in a community as the number of primary care doctors goes up. Dartmouth did a brilliant study, and I apologize to my professors for not remembering the exact numbers, but there is a significant reduction in death or mortality in a population as you get an increase in primary care doctors. And conversely, the other way, and again, maybe the specialists would tell me again it's skewed because people go to specialists to die, but the more specialists that are there. In fact, at Parkland, we used to call it a rest in peace consult, and that's when you had a renal, infectious disease, and pulmonary. A lot of the humor in medicine is dark, in case y'all hadn't noticed.